Thank you, Silke, and thank you really much for this very kind introduction. So, sorry. These are my disclosure. And as you know, why should we care? So sometimes, you know, when I started all to speak about women, and I always said it's so important because you have to be practical in life. Excluding, let's say, half or more than half of the population, you will have troubles, especially when we are thinking about drug development. And we saw, this is a report from the United States, that 80% of the drugs that were withdrawn from the market were to the side effects to women. So think about when you're doing a trial, how much work it is, how much cost, and you are there as an investigator, you are there as a patient to be involved, and everything. It's a lot of effort, financial, psychological, also organizational, to go through an organization of having a drug license. And I think this is something that it's not only, it's all the global situation of health. Also, when you think that a withdrawal of the drug means lack of trust. Maybe you remember all the discussion about AstraZeneca, the vaccination, how much it decreased the trust in science. So it's very important that we do good trials, involve the right patient in the right trial. So this was already addressed in 1993 by the NIH. There was some, especially for NIH funded trial, there was a request to have more inclusion of women, more inclusion of minorities, as this was already perceived as a big issue for trials. And the same was done by the European Parliament. And you see that this motion, I'm sorry for the little bit busy slides, that the European Parliament requested a better inclusion of women, especially due to the fact that, based especially in vascular disease, there was always already a sensibilization about the undertreatment of women in trials. And George Sigillus and myself, we did some analysis what it meant to have underrepresentation women in trials. So what we realized that, for example, maybe you remember, not all of you will remember, about the effect of thrombolysis in women. There was some let's say, unconscious bias saying, oh, thrombolysis may harm more in women. Then there was some report that it was even better to treat women. They have a better effect on women because maybe they have smaller vessels and so on. But when you put together the data, there is no biological difference in treating women. We are not talking about pregnancy and a special condition, but there's no difference. So it's very important that if you have the data, thanks also to the IST-3 trial, which was the, let's say, most inclusive trial for thrombolysis, we realized that there was no harm and no special condition why women should not be treated, and especially elderly ladies. So this is a very important paper published by Cheryl Cassell and by Else Sunset and many other, and Peter, our moderator, our convener, that looking at all the vascular trials, that there was clearly an underrepresentation of women in trials. And you see, especially in women below 70, which is, I think there is some reason for this, intracerebral hemorrhage, which is also one of my favorite arguments in stroke research. We see there seems to be less difference in acute trial, which is also easy to understand because in the acute state, there's not much time. Sometimes you have to say, okay, it's something that immediately can change your life. While it's much more difficult to involve women for longer controls and for having follow-up like 2 years, that they come back to all the monitor visiting and so on. And you see there's almost no difference about the regions. And so I believe that we really have a problem, especially we cannot afford that drugs are withdrawn from the market due to the fact that there are more harmful effects for women. And so we need to have a decision model. So we have to be, what I said, we defined the problem. I said, this is the problem, and we know it's not longer a question that women are underrepresented. And you heard this already from Susanna. I think was showing, I didn't show you now the slides about the NOAC trial, but if you look at the NOAC trial, the women were all too young compared to what is normally going on. They were all underrepresented despite the fact that CHAS-WASC included female sex as an additional risk factor. So this under-involvement of women in trials will lead later to under treatment. So it's something, if you know what you use what you know, and if you don't know the effects of a drug, then you don't use it. And I think this is a very good atlas of the Canadian Women's Heart Alliance, and where they show very well which are the different targets. And I will face only some of the targets which are more important for us in stroke medicine. As I said already, the women below 70 are less included. Probably, if you look at the broad group, especially when you think about the fact that women can be pregnant during a randomized trial, and you see that often you have long information sheet where there's explaining you that what kind of contraceptive drug you have to use, and you have to be careful not to get into pregnancies while you are on the trial. Same is for your partner. So it's something like, in a way, it's when you need all this information about the risk of getting pregnant while you're doing a clinical trial, then probably you will not say, okay, you will not be so happy to be included in this trial. But I don't think, and this is also, sorry, this is also due to the fact because we had this Thalidomide tragedy. But if you think what it means, this was in the Grünenthal factory, let's say, a company did not really, they had some indirect data, they did not really include it, they did not really have this, let's say, this anti-nausea drug was used, especially in pregnant women, without data. So this is the fact. Again, we didn't have data. It was like sold like it's safe, because there was some evidence from the laboratory. There were no, they had some animal studies, but it was not really well enough studied. So this was in a way something that blocked many years the research on pregnant women. And I believe what was, let's say, what is now the tendency, and this is a very good article from Rieke van der Graaf, that women should be included. Not, there should be a reason why not include pregnant women in trials. So it's that we should not, or let's say, they should not be solely excluded for the fact that they are pregnant. And this is a way to have data. When I was pregnant 30 years ago, and I had to take, let's say, some paracetamol, even then it was, we know that there was no, let's say, that there was no side effects, but they looked at me, you should suffer, better not to take any drugs because you are pregnant, and so on. And or the other point is that we have to develop specific trials for pregnant women, because now what we know, don't forget that if you look at the data, the women are getting pregnant much older. They're over 40, which is fair, because women want to be they want to be now they want to study, they want to have steps for their career, which I absolutely understand. It was not let's say 30 years ago. Let's say it was not really, my pregnancy was not really planned, so I was very young, but this is not what we said, the normality. Now women wants to wait, and this carry more risk, because the older the age, you have more the likelihood to have some more vascular risk factors. So we have to be prepared also for this, and prepare our women and have data on these women. But the other, let's say, dark side of all exclusions of women are our elderly ladies. And our wonderful elderly ladies, which are, we know that there is a kind, especially when you look at countries like Italy, where we have a low fertility, and let's say we have this opposite population graph with old, let's say a broad range of older patients. We have to take care of this lady, or we decide not to treat them, or not to have them coming to a good, let's say, age, and say, okay, they are out of our healthcare system. If not, we have to support them to be healthy and to have the best way of living. And we know also that when we exclude this kind of women or this kind of patient, and these are mostly women due to the fact that we tend to live longer, we have a quarter of, we have more in many trials, we have based on the inclusion criteria, we have 80% of the patient excluded, and this can go down up to 50%. So it's not something that we can afford any longer. When I started to do stroke trials, the age limit was 80, and after IST3, and now we don't have this upper age limit, which is clearly something in favor of randomizing elderly ladies, but still we need to support them. And this is even worse when we think about minorities, because now we will see also in Europe we tend to have more minorities. We will have refugees, and these women will be excluded. Now we have more data from the US, because there is already more sensibilization, but it's something that we also will need to face in Europe. And you see, it's not so much I think after all this Black-White Lives Matter, luckily there's more sensibilization about patient of color, but we have an exclusion of the Latinos, which are now the most new target of patients which need to be included in trials. So again, targeted let's say campaign to get them inside the studies. You know, it's a lot of mistrust. So you need to understand what is the point, why our patients don't trust you and are not so willing to enter in the trial. Probably they feel in a way that they are not looked as white patients. They don't feel taken seriously as white patients. So often they cannot afford to pay for the medical services. Regarding this, I think one of the best trials which has been published recently is the SOSTART, because what did they do? They were very pragmatic. They included, you know, the SOSTART trial is they compared anticoagulation with no anticoagulation after intracerebral hemorrhage. Beside the results, it's the design, which was, I think, extremely pragmatic, because they could, they allowed to enroll patients who did not have the capacity to consent, because also this, excluding patients who don't have the consent, the capacity to give the consent, means that you exclude patient who can benefit from trials, because clinical trials means you have a better possibility to be treated because you are follow-up. So it's very important that you include these patients. And again, we criticize them, besides that they did a wonderful work, due to the fact that they excluded, again, a patient with white, they included only white patient, and they did not include enough women. For the Prestige IF trial, as Silke already mentioned, we are trying to understand what we can do for this patient. We will have questionnaires for patients, for doctors, in understanding what is the best way to include them, because we will try to understand what are the inconveniences. For example, they have a lot of visits, how we can do it, how they feel when there's a forgotten appointment. Or what the other point is that the lack of appreciation of your work. So it's very important to keep motivated. So these are some strategies that we try to involve, to overcome fear, mistrust, to get to help them in their family care, to have mobile technology, partner education, or to have the engagement of the community, and so on. So very important that you understand, you have to map what are all the issues in order to include more women. So this just to conclude, we need gender-based approach, dedicated awareness stroke campaign for women. So they have to understand they are at stroke risk. We have to include more women of above 80. And in some cases, we can stop also the male randomization when we have 50% of male, based on what is the impact of the disease in both sexes. So very important that we overcome what we call we need to de-bias ourselves, because when you give an algorithm, a computer, the inclusion criteria for a study, and probably this computer will include the women. If you as a doctor stay behind, look at a very fragile 90-year-old lady, she tells you with a low voice, very slow, you probably will not include her. So you have to de-bias yourself, because you as a doctor need to include a patient, because a trial is an opportunity for the patient, and it means that you can deliver better stroke care. Thank you very much for the attention.